We are born free.
And we will die free.
The time in between, though,
that's complicated.
In that time, governments, institutions, and our egos will limit our ability to find true freedom in this life. These are real stories of real people overcoming the odds, persevering in justice, and unlocking their potential. Welcome to Finding Freedom. Here's your host, John Odermatt.
Hey everybody, welcome back to another episode of Finding Freedom here on the Lions of Liberty Network. Great to have you here streaming live on a Wednesday night for the live watchers out there. For those of you tuning in on Monday when this is released, thank you for listening as well. Please be sure to subscribe to the podcasting app that you are listening on. But for the live watchers, now we are on Facebook, YouTube, Twitter, and Rumble with a new channel. I finally have my Finding Freedom solo feed Rumble channel, so you can subscribe to that. That would be very much appreciated. Today, we're going to be talking about, something that I think we haven't addressed directly on this show, but certainly with different guests in the past, I think we've talked about aspects of medical ethics, aspects of maybe medical malpractice and things of that nature. My guest today, let me bring him in and we'll do the introduction. My guest today is Ryan Crim. Ryan was on Finding Freedom back, I don't know, maybe a year ago or so. And was it about a year?
Yeah, I think so.
Yeah, and for that, we pretty much entirely talked about Haiti. Ryan is very involved and active with various organizations providing aid to Haiti. And while it might be, in the news cycle now with Haitian immigrants being in the news, coming up in the Trump debate, we're not going to focus on that today, but we might have another show down the road here to address that. Today, we're going to focus on medical ethics. Ryan is a family physician. He graduated with a degree in ethics from Cornell in 1993, graduated from Georgetown Medical School in 1997, and then completed his residency at Wake Forest in the year 2000. If you could do the math, I think we talked about this pre-show. He's coming up on about 25 years practicing. So that is quite a landmark there. Ryan, welcome back to Finding Freedom.
Thank you for the introduction. It's great to talk with you again, John.
Yeah, well, great to have you back. And I know that what we're going to talk about today is something that you are very passionate about and you have your own opinions on. It's something that I am not as well versed in, of course, not being a doctor, so I'm not as familiar with the guiding ethical principles of medicine. But, I think once we get into talking about them, they're not hard to understand, but there is, I think, quite a few areas of, nuance. I think we can definitely talk through that. I'm sure there's a wide variety of opinions within the medical field on some of these. But before we go any further at all, let me just give you a chance to give any more of an introduction or anything else you want to say to yourself, so the wonderful Finding Freedom audience can get to know you better.
Anything about myself before we go into ethics? We have 5 children. We had 3 dogs. We're down to 1, but and backyard chickens. We have a garden. Try and eat clean and healthy, and sort of practice what I preach. I think that carries weight when you're talking to people about their medical issues. And I love being a doctor. It's a lot of fun. It can be really hard and really sad at times. It can be really long hours, but it's a blessing and a privilege.
Well, that's one thing you want to hear from your doctor, that they love being a doctor. I don't want to hear from my doctor that, man, I hate getting up in the morning, going to work. So that's a good thing.
Thanks, John. Yeah.
So let's get in at a high level. If you could just introduce each of these principles of medical ethics, and just give a couple sentences, and then we'll dive deeper into each one.
Absolutely. All right. So, I mean, I'm going to try and not say so as much during the show. Medical ethics, the guiding principle that sort of the rest of these four principles come from is what's called primum non nocere, which is Latin for first do no harm. So that's sort of the overarching principle that lays out these next four tenets. And the four tenets of medical ethics are autonomy, and that means respecting a patient's right to make their own decisions about their health care. Something that sort of got lost in that year of 2020, I think.
Mm-hmm.
Then there's beneficence, and that means we have a duty to do good for patients. Non-maleficence, that means we have a duty not to cause harm to patients. And then justice. Justice is interpreted in many different ways, but basically it means you treat everyone fairly and equally, no matter who they are or where they're coming from. But oftentimes it's applied more globally, as to a societal justice versus just justice in applying fair and equal treatment to each patient that you're seeing. And everybody who has an interest in medical ethics tends to take these principles, and they'll have one or two that they sort of favor over the others.
What's the reason for that?
Well, a good example would be justice, right? So
Mhm.
back in 2020, right, justice was the reason for a lot of what the people in charge thought they were doing was right. They thought that by doing the masking and the closures, that they were going to bring about the most good to the society as a whole. So that's how they probably would justify it from an ethical standpoint. Now, obviously, with hindsight, and even with many people during that time, you could look at it and say, well, there's a couple of things wrong with that. We really didn't address the patient autonomy at all, or which to me, that's my, with coming from a libertarian background, that's sort of the highest principle that I view when I'm practicing medicine, is the patient's ability to decide for themselves what they want. Whether or not I agree with them, it's their body, it's not mine.
Mm-hmm.
And so focusing on that principle of justice is sort of what drove, I think, a lot of the recommendations and decisions that happened.
Yeah, and we'll save justice for the end, because I think there is some
tough
really
one.
interesting discussions around justice, just for those reasons you highlighted.
Yeah.
But to start with autonomy, and you mentioned that you are a libertarian, and really this one at a high level comes down to people own their body, they own themselves, and they should be allowed to to make the decisions that they want to, how they want to treat their body, what medicines they want to take, if they want to get a vaccination or not, things of that nature. So I think, just to go back to COVID again, and I don't know if this is the best place to start, but with vaccines, I think, myself included, I had never really questioned vaccination before when it comes to childhood vaccines. I've always questioned the flu vaccine as being necessary for a healthy individual, as people can generally deal with the flu from my experience, if you're healthy and have a healthy immune system. But my shift in vaccines, after really learning about the COVID vaccine, and how really it's not really a vaccine, and we don't have to get too in the weeds on that, but at the same time, you start to look in what kind of tests are they doing on these vaccines, and to get into the childhood schedule, and the vaccines by themselves might be great, but then you're taking this huge dose of many vaccines at the same time. So I guess what I'm getting at with this, so with regards to autonomy and people making their own choices, I think you've mentioned before that your view on the vaccine angle has changed a little bit.
Yeah, it has. So like I said, so I think that my view changed even prior to COVID, with not so much my view of what good vaccines have brought about. We basically wiped out polio with vaccines, and that was a big win. So there's certainly some vaccines out there that clearly have done well for not just the individual, but the entire globe. Smallpox is another one. You don't really hear of people getting smallpox anymore. But I think the thing that changed it was there was a movement shortly after I started my practicing as a physician where people didn't want to get vaccines. And what was happening is there was a big pushback from the medical community, where a lot of times they would just decide, okay, well, if you don't get the vaccines, and that stance has only hardened over time, they were kicking patients out of their practice, right? And I just felt that was not doing what we as physicians are supposed to do. Because let's say you are questioning a vaccine and maybe don't want to get it. We have several of the plain community in Pennsylvania here, as you probably know. And a lot of them, some of the vaccines have some lines from fetal tissue, right, from aborted children. And the lines where those vaccines are produced come from that. And so a lot of the plain folk didn't want them. And also a lot of people who were very religious didn't want them. So these people were getting kicked out of practices because they didn't want to get this vaccine that had those lines. And then there were some other reasons too. And my thought is, it's not the child's decision. So one, as a physician, if you're kicking a parent out with the child, kicking the child out because of what the parent's saying, you're not doing the best you could by that child. And two, what are you creating as a physician if you just say, hey, you're wrong, I'm not going to see you anymore? And that's for anything. Like, that's just gonna, if they already have some misgivings or trepidation, like, you're creating this environment that is not welcoming. It's like, and the patient will leave with this idea that all doctors are bad. So that sort of formulated my opinion, and then I guess that only hardened through those COVID years.
Yeah, I was going to say that's still incredible. At least what I'm familiar with pediatric care. I mean, unless you're going to stick to the vaccine schedule, I don't know what the percentages are, but it seems like 80% of pediatricians or something won't see the child, which is pretty insane when you break it down. And doctors are supposed to be guided by these principles that individuals and parents making decisions on behalf of their children should be able to make decisions that they feel are right for themselves and for their kids.
And just from a logic perspective, you're right. Like, if you as a physician kick that child out of your practice, you are never going to get that person back, or that person to think your way, right? So if let's say I was a physician, I totally believed you have to get these are really important. It doesn't make sense to kick someone out. Your argument would be, okay, I understand you're a little nervous about this. I'm going to give you some research about it, why I think this is a good thing, and advocate for your position, as opposed to just saying, that's it, we're done, goodbye.
Mm-hmm.
I mean, it blows my mind a little bit that happens.
It's also a pretty bad business model. I guess until recently, it probably didn't matter since there wasn't much traction. There weren't many people going that route. Maybe, with the marketplace, maybe, it gets to a point where there's more people leaving that it would affect bottom lines. I don't know if it's at that point yet.
Yeah.
Another area which I think is kind of interesting is end of life care, and what I've seen you write about, with regards to individuals making decisions ahead of time, maybe having living wills to dictate, what kind of care they want and when they want. I kind of hate this term, but when they're okay with the plug being pulled. I don't know what what's the medical terminology for that, to say it in a nicer way.
Euthanasia.
there you go.
How are the kids doing in China? That's what we say. It's a joke.
But the I think something that maybe it's not as common in the United States, at least not yet, but you hear more about it in Canada and in Europe, where there are young people making decisions to end their lives, and and doctors, supporting them in that decision and helping them to end their life. And I just wanted to get your perspective on that type of practice.
Man, that's a weighty discussion. So there's two forms of euthanasia. There's what we call active and passive. So passive would be more like what you said, pulling the plug. For example, someone has a stroke, a massive stroke. We could potentially keep them alive indefinitely. Their heart pumping, giving them nutrition through a tube or through an IV, and they stay in the comatose state, and their likelihood of recovery is almost zero. There was that big case, years ago, it was in the news a lot, Shriver, do you remember that? Shriver, I
Yeah,
think,
sounds
in
familiar.
Florida. And that case, among many others, was talked about a long time, and you'll find all of that stuff in like the ethics textbooks. But that is a little bit of an easier position, especially if you have a living will and have talked to your family about what your wishes are before you die. So we as physicians, we're supposed to, and me especially, advocate, let your family know what you want, because if you get into a situation where you are not able to make those decisions, it's awful on families, and families fight, and it's tough, very tough, to navigate that. But if you're in an active state of dying, or that comatose state where the likelihood of coming out of it is pretty small, it's an easier decision, I think, for if you have that living will, where the family's like, okay, this is where we are. We can keep this going for as long as years, but it probably is a wise decision to know what you want. And either way you choose, that's up to the individual, going back to the autonomy again. Active euthanasia is more where someone comes in and wants to end their life. They have a bad terminal cancer, and they just don't want to go through treatments, and they want to end it now, is an example. And that would be where you provide a patient the means to end their life, medication wise or otherwise. That's a bit trickier, I think, because what's supposed to happen is they're supposed to go through a very intensive screening process to make sure, this is not depression, this is not suicidality, this is a conscious decision, and they want to avoid pain. And one of the things that you'll hear talked about a lot in sort of medical circles is, if you have pets, what do we do with our pets? And when they get old and weak and can't walk or can't see or are having other issues, a lot of times we'll have the animals euthanized, right? And most people think of that as a good thing. And so the argument for that type of thing would be saying, hey, you're preventing suffering. I am not a big advocate of what I call active euthanasia. I personally don't think that is how we're supposed to go, but based on autonomy, it wouldn't be something that I would say a person couldn't decide. The problem is like you were saying with Canada, is when the government steps in. And there was a case in England where the family had a child that had a lot of medical problems, probably was not going to survive, but there was a potential for treatment. I think it was either in Italy or the US, and they forbid the family from taking their child out of the country.
Yeah.
I'm blanking on the name, and so that's a different situation, so it should be really a very personal decision, and the person who's making that decision should go through the process of seeing someone and making sure that they're not actively suicidal, and this just isn't the depression talking.
It seems like there's some overlap there between the the autonomy aspect of that and the beneficence, tough word to say,
Yeah.
aspect of that. Because with beneficence, essentially that's focused on, medical providers should do their best to do good and prevent harm. When you're talking about especially active euthanasia, ending someone's life, I mean, it doesn't get much more like there's no coming back from that.
Right. Yeah. It's a final decision.
Yeah. So, I get let's I guess before we move off of it, is there anything else with regards to autonomy that you want to address before we move on?
I mean, I think autonomy to me is the number one principle when you're talking to people, right? And I think as physicians, if you truly believe that something is in the best interest or going to lead someone to the best health, you should advocate vociferously for what you believe in, whether that's a vaccine, whether that's a certain medical treatment or otherwise. But at the end of the day, you also need to be willing to accept what the patient says they're going to do. And you might feel like that's actively causing them harm. Um, I'll give an example. I had a patient who is an alcoholic. He drank a case or two of beer every day. And he'd come in and he had high blood pressure and high cholesterol and all this stuff. And I'd say, well, you should take this medicine, this medicine. And he'd say, okay, doc, and he'd leave. And he'd come back and we'd do labs. Everything, blood pressure's still high, cholesterol's still a mess. And so, can I curse on your show or not?
You can, yeah.
Okay. So one day I just got really mad and I just said, I don't know why the fuck you come in here anymore. You never do anything I say. And he kind of just looked at me, and this was a realization for me, a good moment. And he kind of put his hand on my leg and he said, Doc, I just like talking to you. And maybe one of these days I'll listen to you. I said, great. Let's save ourselves some time. You come in, we'll sit and we'll talk hunting or fishing or whatever you want to talk about. And when you're ready, you'll tell me. He said, yeah. And I think that was a big eye opener for me. And eventually, over a period of years, he changed his ways, which was a big win.
Mm-hmm.
And I think I would have been aggressive and just really yelled and, I never would have made that change.
So there is an element of sales to
Yes.
being a doctor, getting your patient to take their medicine. Yeah.
Right. Yeah.
That's
for
interesting. So moving on to beneficence, and we introduced it there. If you want to expand on that very high level introduction I did.
Sure. So beneficence is basically to do good, right? And so whether it's whether you're talking to the patient about losing weight or you're giving a medication, you want to make sure that that treatment that you're giving is not going to cause harm to patients. So there's a secret in medicine, and it's not widely talked about, but almost every single physician at some point in their career is going to kill someone. And that will be either because you didn't recognize what was happening and didn't act fast enough. You thought you were doing the right thing by giving this medicine, but you should have given a different medicine. You made a bad diagnosis. There's 100 different ways. So a lot of times you'll see those statistics of like, well, people are dying in the hospital. But in a lot of these times where physicians are in, when a patient's in a critical condition and there's seconds or moments to act, you have to make the best decision you think you are doing at the time. So beneficence, and a lot of times you make not a lot of times, but there are times where you'll make the wrong decision and that will cause end of life. That doesn't mean that the doctors are doing the right thing. They're couching it in terms of like, I think this is the best treatment that I know of at that time. And so with beneficence, yes, you really want to do good, but you also have to remember as a doctor, you're not always going to make the right decisions. And But with that being in mind, it sort of drives the idea that you better make sure that that medicine that you're writing for is the right one, that they're not don't have an allergy to the medicine, it's not going to interact with other medicines. Um, One of my biggest pet peeves is I'll have people come in and they're on 20 or 30 different pills. You have no idea what that is doing in a patient's body. Most of this stuff that we call that polypharmacy. If once you get about 3 to 5 medications, prescription medications that the patient's taking, um, you you don't know what's happening, the interactions between those medicines inside the body. Now,
'Cause
sometimes
there's never been studies done with that with
right,
that.
yeah, they mostly
Yeah.
study is like 3 to 5 drug interactions, and once you get above that, like I said, I have patients on 20 or 30 medications. I love stopping medicines. Like they'll and the patient will come in and say, well, I'm on this pill, I don't know, I feel tired, stuff. I was like, all right, stop it, see what happens, and if we need to restart something else, we'll do it that way. So beneficence is, you need to, every time you're talking to a patient, you need to make sure that you have their best interest in mind, not your best interest, not a
Mhm.
pharmaceutical company's best interest, not your corporation's best interest, it's the patient's best interest.
So, do you think that is an area of concern with a lot of doctors not having the patient's best interest in mind? You mentioned pharmaceutical companies. I remember when my wife used to work as a server at the Capitol Grill in downtown Pittsburgh, which is a very high-end restaurant, and on, Thursday and Wednesday and Thursday nights, they had a big event room where they would bring in pharmaceutical reps, and a bunch of doctors would come in, and there'd be a presentation and a steak dinner. And, um, that's the way that pharmaceutical reps are pitching their products, their drugs to doctors. So do you see that as an issue?
Um, I did, and for a long time, I mean, I've probably gone to 2 of those dinners in my lifetime. So I'm not a big fan specifically because of the reason that you say. And when you get those studies, I mean, I don't mind seeing the drug reps. They have a job to do. Most of them are nice people, and so when I was younger, I was a bit more of a jerk, but I think gathering the information and then also doing the research on your own. So you have to remember that there are maybe 500 to 1,000 new drugs coming out every year, and about a quarter to half of those drugs, probably about a quarter or less, I would say, are eventually removed from the market because of side effects, or they find out they don't work very well. So um, yes, the sales aspect is a job. There's a lot with the pharmaceutical industry I could talk about. We could talk about the government and regulation, how long it takes the medicine to get to market, how much money they have to spend in the US compared to like European countries and things like that. And a lot of times, the other things that happens with pharmaceutical companies, they make me too drugs. And you'll see that, let's take a cholesterol medicine. So the one pharmacy will come up with a blockbuster, let's say pravastatin. It's a really old cholesterol medicine. Well, all of a sudden, there's 6 other cholesterol medicines. Each one's claiming that it's this much better than the next one, right? And they're selling their product when all of them work and all of them have the same side effects as well, right? So some of that drive is capturing market share. So that's certainly a problem because it's driven by their financial interest to fund their studies to do the research. What you're not seeing of is a lot of new antibiotics. Why? You don't get paid for antibiotics, right? There's already enough good antibiotics. So a lot of that research is
Until the ones that are out there all stop working because
right.
they're
Yeah, exactly. So right, but yes, I do find some of the sales techniques are not good. I Again, I know a lot of they'll come around and talk to me, and I like my reps. Like I said, I used to be kind of not very nice, and now I'll talk to them and listen to what they have to say, and then do my own research. So
yeah. And I'm glad you brought up antibiotics. Um, because I think there's an aspect to antibiotics that, especially with new research coming out, the damage that's done by cycles of antibiotics to your gut microbiome, and then the cascading effects that can have on your health with autoimmune disease and things of that nature. I'm not antibiotics. I'm not completely against antibiotics. In fact, I just took a cycle of antibiotics a couple of weeks ago. I had a skin infection from a bug bite that was one of the weirdest things that's ever happened to me. And I knew almost immediately that I'm going to need an antibiotic, because when you get a bug bite and your whole calf muscle starts hurting, that's concerning.
Yeah, the
But
cellulitis.
yeah, I think that's what it was. They weren't 100% sure, but they were pretty sure that's what it was.
Yeah.
So antibiotics, and I think you could even lump pain management into this question as well, where obviously pain management and doctors overprescribing pain management medication had a big part with the opioid epidemic, and put a lot of people who really weren't doing anything wrong per se. They went to their doctor, they had back pain, they had hip pain, they had some sort of chronic pain. Their doctor gave them medication, and they ended up getting addicted to it, and in many cases had catastrophic effects in their lives, sometimes leading to an overdose. So kind of two sides of it with pain management and antibiotics being kind of this background. If you have overprescribed antibiotics, in the background, maybe things that could be happening in the body, which could lead to other chronic issues, and overprescription of pain medication, maybe directly leading to addiction. So just want to get your perspective on those two things.
Sure. We'll start with antibiotics. And my wife, she's also a physician, and she has a good trick. So when you come to the doctor, you're taking time out of your day. You might be losing money because in your work hours, and you want something to be done. So this is an interesting ethical conundrum. Many, many years ago, there was a medicine called Obical. And if you flip that around, it's placebo spelled backwards. So someone would come in with, you knew it was a cold, but you also knew that they would be angry if they left without getting a pill. So you'd prescribe, this was before my time, this is back maybe in the 70s. You'd prescribe Obical, and they go to the pharmacy, and the pharmacy fill it, and it's a sugar pill. But they felt better. Give me some of that Obical.
Placebo is a real thing. It's a real
placebos thing. Are a real thing. But right, so differentiating between a viral illness versus a bacterial illness, right? Antibiotics don't do anything for viruses. But again, a lot of what we do in medicine, you have patients that come in and they want to be fixed right now. And I need that Z-Pak, and I need that amoxicillin, I need my doxycycline, whatever that antibiotic may be, and it's not. So you're faced with the decision of, you have a patient in here, it's going to be a discussion. It's going to take time. They might leave angry and not come back to your practice because they didn't get the pill they want. So do you sit down and have that long discussion, or do you just write the script and then move on to your patient who's dying of cancer in the next room, versus spending time? And so I think a lot of times it's easier for us to write the script. And so trying to get away from that, right? And it is tough for some doctors, because one is, a lot of times, especially if you're going to an urgent care or an ER where you don't have a relational with a provider, it can be harder for them to influence it. And a lot of times people leave mad. But you just have to have that discussion, because so many of these things are viral in nature, and we really don't need antibiotics to treat them. And the thing is if you're still sick in 7 days, or if you're getting worse, let us know, and then we'll reassess. Mm-hmm. So yes, a lot of times antibiotics are written more out of convenience and fear of, and I will say this too, especially for nurses and ERs, and even in medical practice, not so much in the family medicine practice because we tend to know our patients, but if someone's coming in there, they feel sick, they feel awful. If they don't get what they want, they're angry, and there's a lot of workplace violence in medicine. So I tend to over, but in reality, again, beneficence, do good things. You're not necessarily doing something good by just giving a patient an antibiotic, right?
Mm-hmm. It's a fine line. I guess it kind of bridges over to to the next one.
Malfeasance,
Not non-malfeasance, do no harm. Right. Is it doing like how would you? Is it harm? I mean, it's I don't know. It's
well, that it's an interesting. So that'll transition us into the pain discussion. So let's say, John, you break your leg. You really shattered it. You were doing a backside 720 on your snowboard and caught the tail and flipped, and you just destroyed your leg and your pelvis. And you're coming in and you get the surgery, you're all fixed up, but it hurts, right? It hurts a lot. You really don't want to get up and walk, and you just want to feel better. So, okay, I think you can get by with Tylenol. We'll give a couple pills, but oh man, that worked really well, and I didn't have any pain, and can I just have some more? And doctors fall into that trap. Well, yeah, I don't want my patient to have pain. I'm doing something good by giving them this medicine, and they're able to get up and they're going to heal faster. But then the converse of that is, let's say we didn't have any pain medication and you broke your leg, same sort of situation, and it was fixed enough, you didn't need surgery, but you're laying in your bed at home, and your wife is like, John, you got to get up and move. No, it hurts. It just hurts too much. You got to get up and move, John. No, it hurts too much. And she caves and starts bringing you dinner in bed. And then you just get weaker and weaker, and eventually you're never able to get out of that bed. Mm-hmm. Right? So there is that idea of beneficence, do good, but sometimes doing good means you have to go through a little bit of pain to get the outcome that you want.
Right.
So, John, you got to get out of bed and walk. It's going to hurt, but it's the only way it's going to get better.
Yeah, well, that's actually a pretty real example. I didn't hurt myself snowboarding, but I tore ligaments off the bone in my ankle playing basketball years ago. Had to get ankle surgery. Sure enough, after the cast came off and the boot came off, and I tried to walk, my heel was just on fire, and I called my doctor up and I said, "Is this normal that I can't even walk? It hurts so bad." And he's like, "Well, you just have to grit your teeth and get through it. It'll loosen up." And it did, with physical therapy too. But yeah, you sometimes just got to get up and move your body.
Yep, for sure.
So I don't know. Do we need to talk about malfeasance separately? I mean, that kind of goes hand in hand with beneficence.
Yeah. Beneficence is do good things, and non-malfeasance means don't do harm. And like I said, that sometimes can be a little bit challenging because sometimes you need to do harm. A lot of medical schools have adapted, don't really use the Hippocratic Oath anymore, because in that it says don't cut, and it's talking about surgery and things like that, right? So in surgery, you're causing harm. You're going in, you're cutting open skin, you might displace organs, right? So technically that's harm, but you're doing it to do good, right? Mm-hmm. And it's the same thing with that pain example I gave you. Sometimes you gotta have physical pain to get to the good part.
Yeah.
Yeah.
So the last one here, you put it last, I think for a reason, justice. This is a word that outside of medicine, you want to talk about social justice or criminal justice. It's just a very, very difficult word to nail down, because so much of it has to do with fairness. What is fair? And what is fair for one person might not be fair for another person. So it's tricky to, at least in my perspective, in this context. Of course, if we get into criminal justice, I think there are definitely clear laws, right and wrong, where it's easy to make that decision. But when you get into these nuanced areas, especially when it comes to medicine, and if we're going to talk about COVID-19, the situations with COVID-19 when it first came about, and doctors were telling patients when they would come in, there's nothing we can do. Just go home. If you're on the brink of death, come back, essentially. That was like the instruction. And I know there's been, doctors who have spoken out against that, Dr. Peter McCullough, Dr. Robert Malone. Peter McCullough at the time advocated for, and maybe still does, for a similar cocktail of drugs, steroids and things like that to try to figure out how to treat people to give them some sort of relief. So that's just sort of a rambling statement. It wasn't a question, but I'll hand it over to you.
Well, so justice, as I interpret it, is you want to treat each patient individually as you're seeing them, fair and equal. So let's say a patient comes in, we'll say, to make it simpler, we won't go into like race or gender and all that other stuff. We'll just go with, they have different political beliefs than I. And so being just, they're allowed to have their beliefs. That doesn't mean I'm going to treat that patient differently. I think coming to mind, did you ever watch MASH growing up?
Yeah, it was when I was in like middle school and high school. It was on every time I turned on the TV, the reruns of it.
Right. So there's one episode in MASH where they get in wounded North Koreans. And the one doctor, I forget which one, was not going to do the operation because it's the enemy. And they said, no, you do, this is the patient before you do the surgery. Right. And so they did it. That to me is justice, right? That concept of that individual as a human being. Yes, they're your enemy out there, but they're still the patient in front of you. You treat that patient, you take care of them. All right. When justice gets applied more broadly, for me, that goes, are you familiar? There's two basic ethical systems. And since that, everything's spread apart into there's little case-based ethics, all kinds of stuff. But the two big ones are deontology. So that's a rules-based ethics, right? So for Christians, it would be like the 10 Commandments. Those are your rules-based system. For you can have a non-religious aspect to those principles too. Don't lie, don't steal, all those kind of things. They don't have to be biblically based. Whereas utilitarianism, and that's the thing of doing the greatest good. I just don't. I can't stand that concept, because what is the greatest good? How do you know you're doing the greatest good? Right? How do you know that action you can't, right? But people the people who are utilitarians, and there's some libertarians who are, I just don't know how they're libertarian and justify being a utilitarian. But anyway, that leads into that concept of justice. Is justice to me, when it's applied more broadly, always leads to utilitarianism. And I think that's not the right way to look at justice. It talks about distribution of resources. So in medicine, let's say there's a mass casualty, right? And you actually have a better one. You live in Pennsylvania, and this is where justice was not applied equally. So you do see this in medicine too. Do you remember, not Bob Casey now, but Bob Casey's father? He would have been when you were a kid.
Yeah, not really.
All right. So Bob Casey's dad had liver failure and he needed a liver transplant. Well, the transplant rules are set. However, Bob Casey's father, who also was a senator, sort of jumped the line and got a free liver ahead of all the other people. That is not justice, right? Mm-hmm. So applied in that way, I think we should stick to our rules in medicine. Justice is really hard. So a lot of times, like I said, in COVID, they applied justice, thinking they were going to do the greatest good for the greatest amount of people by locking everybody in their homes, shutting everything down. Clearly, with hindsight, I think you want to assume we call it assuming good intent, which is questionable, I understand, but you want to assume that those people really truly thought they were doing the right thing at that time. But at the same time, you have families with mental illness, families that missed cancer diagnosis, families that missed screening tests. So did you do the greatest good for the greatest amount of people, or did you cause a lot more harm by shutting the country down?
You families that couldn't attend a funeral for a loved one, or had to sit separated by 6 feet when they're in the funeral service. Yeah, what's the mental residuals from that?
Right. And I don't think that's ever been looked at. So even from their own perspective of where they thought they were doing the greatest good for the greatest amount of people, how do you judge that? What's
Mhm.
the scale that you're weighing that on, right? So, okay, did you save lives? Maybe you did, maybe you didn't. Maybe you caused more deaths by, all these more harm, more mental harm, more harm with education, all that stuff, right?
Yeah.
How do you know? That's why justice is a tough one. So justice for me is more about you see that patient and you treat that patient because they're a human being and they're your patient. Doesn't
So
matter. Go ahead.
go ahead. Go ahead. I've started a new thought. So go ahead. Yeah, finish what.
No, I was just it doesn't matter the color of skin, the race, their gender,
Mhm.
political beliefs. I don't care. Trans, not
Yeah.
trans, whatever. They're a patient. They're a human being. You love them. Like you, I'm a Christian. God says,
Yeah.
take care of your people, and that's what you do.
Yeah, and along that note, so we're both Christians. When you talk about justice, and people will say, "Well, justice is everyone should have a right to health care," and the libertarian in me comes back and says, "Well, if you do that, then you're making slaves out of your healthcare workers. Who
Right.
owns the time of your doctors and nurses and all your healthcare, administrators?"
So I
So
like. Go
how
ahead.
do you respond to that?
I think everyone should have the right to access healthcare. And that's the difference. You don't have a right to demand what you want, what treatments you want, what that you don't have a right for it to be free or paid by other people, but you have a right to access to healthcare. And I guess when and so that's the difference. Does that make sense?
So just to make sure to steelman that. So what you're saying is that if I were to come to you and give you money and ask for healthcare, you're saying that I shouldn't be denied. Is that
Right. Like,
essentially?
I really don't like guys with mustaches, but so I'm not going to see you, John. Yeah. So that just because you have a mustache, doesn't mean I get the right to turn you away.
Yeah, that makes sense. And when you start to say healthcare is a right, then I mean, what does the system become at that point?
Right.
As
So, yes, I don't think saying that you have a right to healthcare or a right to housing or a right to food. I mean, you could go down all those
Mhm.
things are positive rights.
Right.
So you don't have a right to be not denied access to them, but you don't necessarily just by nature of your birth have a right to just get those things free.
So we are over our time a little bit. Can you keep going for a few more minutes?
Sure, yeah.
Um, before I move on, was there anything else? I do want to talk about, really the current state of medical care with regards to training. I know that's something that you're passionate about, doctors being trained, and really the aspect of, I know you talked about in your time coming up, really the amount of hours that you had to work and sort of the positive, negative benefits with that. I guess sort of the trial by fire of having that intense workload. So with regards to that, I guess before we move on, was there anything else you wanted to touch on um, with the ethics before we move on to training?
I think we covered a general basis. I mean, we could do hours on ethics alone and stuff.
Mm-hmm.
Um, it's a great topic. It's an interesting topic, and it's one I don't think physicians get enough training in.
Do you have any recommendations for if people wanted to read more about it, where you would point them towards?
I would look up Dr. Pellegrino. He has since passed on. He was a Jesuit, so I don't necessarily agree with every sort of thing he wrote about it, but he's a good resource to start with. And then there's a lot of other. I mean, he wrote a textbook. Then there's a general textbook just called Bioethics. And the other thing with ethics, I guess I'll touch on one thing really quick, is what your principles are today should apply to the principles down the future. So in medicine, especially, you have to think about things like what's coming on the horizon. So a good example would be designer babies, right? Right now, we're doing a lot of DNA research and trying to find out if people have certain syndromes. And the reason we're doing that is so maybe we can prevent a disease from happening. One of them is colon cancer, like familial polyposis. And if you get that, then they'll get more frequent colonoscopies. But the eventual goal is obviously DNA manipulation. Well, if we start doing that, are designer babies ethical? We don't have to fix that here, but so you have to think about what your principles are, and are they consistent with what the future possibilities could be.
That sounds like a debate episode where we'd have two people. Are designer babies ethical? And that would be a whole thing. Okay, so to get into the training, I know that's something that you're passionate about. You talked about, I know you told me in our chats that when you were coming up, you worked a very intense workload, 80 hours a week. Doctors today, now maybe going through residency, don't have that same time commitment. Do you think that's a good thing, a bad thing, a mix of both?
I think it's a mix of both. The training hours got changed because there was a case in New York City where a resident drove home and they were exhausted, fell asleep, and killed someone. So they was a big national outcry about the training resident physicians. And I'll relate a story. When I was at Wake Forest, there was a hurricane, and I think we had spent the entire week in the hospital, maybe getting an hour or two of sleep every night for a week straight. In that time, though, you learn a lot of medicine because you're just seeing it and you're seeing it and you're seeing it, and you're able to do it in your sleep. You know what you have to do. You know what you have to do with sick patients, and you just do the right thing because you can do it when you're tired. You can do it when you're awake. You just learn so much. And the way you learn is by cases and seeing patients. And by reducing the amount of exposure residents and or medical students have to those cases, they come out not knowing enough. And quite honestly, even when I came out of residency, I thought, man, I'm a fresh new doctor. I'm ready to go. Let's rock and roll. And there was still a ton more to learn, and there's still tons more to learn. You have to reckon there's something like 5,000 to 10,000 medical studies that come out every year. And nobody has time to read all those, but you have to know the big ones and what's changed and what's new and what's the latest and greatest treatment. And is it the latest and greatest treatment? So you need to know a little bit about statistics to apply that. But you also need to see the volume in the patients to understand, okay, I've seen that type of skin rash before. That's not cancer. Or that little dot doesn't look like anything, but maybe it is. No, that's melanoma. You need to go and get that taken off now. Right. But without seeing enough of those, you're not going to learn it from a textbook.
So not to open another can of worms, but what the heck? Right. So speaking of the future and new technologies, what is your view of AI? And when you talk about something like a melanoma spot, where we could see, maybe they already have this technology where you scan a picture of a mole and it goes into a database and it tells you the likelihood that this is melanoma. Is that something that exists? And what's your view on that?
I don't think it exists in dermatology right now, but they are using it in radiology in terms of looking at mammograms and chest CTs and things like that to determine the likelihood. I don't think it's widely adopted yet, but in general, I think it's probably a good thing. Again, we can go back to we didn't talk about screening tests, but that's a whole other object, a whole other subject. But let's say you come in, you have a cough, you're a smoker, we do a chest CT and we see a lump, right? Well, the lump might need to be biopsied. So we go put a needle in your chest, biopsy the lump. It's not cancer, but oh, by the way, we caused a pneumothorax, and then you get an infection. Now you're in the hospital for 2 weeks and you have $100,000 hospital bill. Well, that's not really doing you any good. But if we use AI technology seems to be a little bit more consistent with picking up things that are worrisome versus non-worrisome. It's still in its infant stage. So I think it would be a nice tool to use when applied appropriately. My gut feeling, being an old doctor, we studied, there was a course I had on Sherlock Holmes. And so when I'm looking at somebody, sometimes I can tell what's wrong with them before I even talk to them or ask them a question. Like
Really?
if you walked in with a circumducting gait, your hip is bad, right? Being that observational stuff. And I don't know that AI is good enough in. And the other thing with AI, it's what you're putting in as to what's coming out, right? So you have to have enough volume, and the computer has to be smart enough and have enough data to say, okay, this pattern is this. So it depends on who is putting in that data and what their ultimate goal is. That's my concern with AI, right?
Yeah, I guess the scary thing, or I don't know if it's scary, but potentially scary thing would be if you remove the human element, you remove the human doctors, and it's just an interface with patients being viewed and diagnosed by AI. That scares me a little bit.
It scares me too. I don't think we're going to be there for a long time, though.
Let's hope not.
Yeah.
All right, Ryan. Well, you've been gracious with your time, and I appreciate that. Before I let you go, anything you want to plug or send people to, or any parting words of wisdom?
Yeah, I'll say two things. One is, we didn't talk about it, but I think a lot of times medicine operates in a state of fear, and we worry a lot about something could be wrong with us, something could be wrong with us. And I think that we have to live our lives and recognize that we're all frail human beings and we're all going to die of something at some point in our lives. So live your life and don't be scared, and go out, do healthy things for yourself, and don't over worry about life, if I can put it in the best way. In terms of a website, I would encourage you to go to Reach Out LaFond. I've mentioned that before at the last time. That's the organization I work with in Haiti. We are not what we consider to be a charity. So I don't know how well charities work. I think what we do is try and raise up leaders in Haiti through education so that they can stay in their country and make their country better. Not Americans giving out free stuff. It's investing in Haiti's future is what I see it as. So Reach Out LaFond is good. And lastly, the last thing is, I am eventually I'm working with Jason Stapleton on starting a business in life coaching. Nice. And I'm looking forward to finally so I'll circle back to you when I finally get that off the ground.
Awesome. Well, he's a good person to be working with on that. Yeah. He'll definitely set you down the right path.
Thanks, John. I wish you all the best in your adventures too, man. And I really appreciate the time you've given. Thank you so much.
Yeah, well, appreciate you and appreciate the well wishes, and I'm sure we'll be talking soon. We still haven't talked hunting, so we'll have to.
We got to do that sometime. I have a whole ethical aspect of hunting we can go into too.
Yeah, so. Yeah. There's a lot we can talk about. So yeah. I'll let you go, Ryan. Have a good night.
Yeah, and hey, you have a great one too, John. Bye.
All right, that is a wrap for today's show with Ryan Crim, talking about medical ethics, talking about the changes between medical training between 20, 25 years ago and today. I think we talked about some pretty interesting subjects. Obviously, could have gone deeper in some areas. Intentionally did not do so because I did want to get through everything. But this is an interesting topic for sure. So I think we'll revisit this down the road. With that being said, a couple things before I send you all on your way. I see we had some live watchers tonight, so thank you for tuning in. If you did watch live, please be sure to subscribe and also click that bell somewhere up here on YouTube to make sure to get a notification when we go live, because we are shadow banned. And also on Rumble, if you're a Rumble person, please be sure to subscribe to either the Lions of Liberty channel or my solo Finding Freedom channel. We're also streaming live on Twitter at Lions of Liberty and at John Odermatt. With that being said, that's all I have for all of you, and we'll see you next week. In the meantime, always remember to keep your head up and the fires of liberty burning.